Thank you for this kind introduction. And I can tell you I was there to the talk yesterday because the degree in the art of healing, who studied in Belgium? That's what it's written on our degree, the art of healing, and I love it. So thank you for having me. I come from far, but I'm very happy to be here with you to reflect on universal health coverage. Because there is a lot we put in that. And you'll see that I hope that the slide will be better than the first one. This presentation is exactly a complement and a companion to the previous one that was there with a lot of data, private sector, etc. And I'm going to give you the view of an insider. So from surviving to driving, that's my country. We were even not in process to survive 25 years ago, and we have thrived. So, next, yeah. So I'm going to pass this because this is what you are going to see. And I'm going directly to this video. I said the magic word, click. Because I love this, I love Hans Rosling, is give visual, and he will give you why we need to have hope. Go ahead. Does it work? Does seems to work, but so I see some
visualization is right at the heart of my own work too. I teach global health, and I know having the data is not enough. I have to show it in ways people both enjoy and understand. Now, I'm going to try something I've never done before, animating the data in real space, with a bit of technical assistance from the crew.
So, here we go. First, an axis for health, life expectancy, from 25 years to 75 years. And down here, an axis for wealth, income per person, $400,000, $4,000, and $40,000. So down here is poor and sick, and up here is rich and healthy. Now, I'm going to show you the world 200 years ago, in 1810. Here come all the countries. Europe brown, Asia red, Middle East green, Africa south of Sahara blue, and the Americas yellow. And the size of the country bubble showed the size of the population. And in 1810, it was pretty crowded down there, wasn't it? All countries were sick and poor. Life expectancy were below 40 in all countries. And only UK and the Netherlands were slightly better off, but not much. And now, why start the world? The Industrial Revolution makes countries in Europe and elsewhere move away from the rest. But the colonized countries in Asia and Africa, they are stuck down there. And eventually, the Western countries get healthier and healthier. And now we slow down to show the impact of the First World War and the Spanish flu epidemic. What a catastrophe. And now I speed up through the 1920s and the 1930s. And in spite of the Great Depression, Western countries forge on towards greater wealth and health. Japan and some others try to follow, but most countries stay down here. Now, after the tragedies of the Second World War, we stop a bit to look at the world in 1948. 1948 was a great year. The war was over, Sweden topped the medal table at the Winter Olympics, and I was born. But the differences between the countries of the world was wider than ever. United States was in the front, Japan was catching up, Brazil was way behind, Iran was getting a little richer from oil, but still had short lives. And the Asian giants, China, India, Pakistan, Bangladesh, and Indonesia, they were still poor and sick down here. But look what is about to happen. Here we go again. In my lifetime, former colonies gained independence, and then finally they started to get healthier and healthier and healthier. And in the 1970s, then countries in Asia and Latin America started to catch up with the Western countries. They became the emerging economies. Some in Africa follows. Some Africans were stuck in civil war and others hit by HIV. And now we can see the world today in the most up-to-date statistics. Most people today live in the middle, but there are huge differences at the same time between the best of countries and the worst of countries. And there are also huge inequalities within countries. These bubbles show country averages, but I can split them. Take China, I can split it into provinces. There goes Shanghai. It has the same wealth and health as Italy today. And there is the poor inland province Guizhou. It is like Pakistan. And if I split it further, the rural parts are like Ghana in Africa.
And yet, despite the enormous disparities today, we have seen 200 years of remarkable progress. That huge historical gap between the West and the rest is now closing. We have become an entirely new converging world. And I see a clear trend into the future. With aid, trade, green technology and peace, it's fully possible that everyone can make it to the healthy, wealthy corner.
Well, what you just seen in the last few minutes is a story of 200 countries shown over 200 years and beyond. It involves plotting of 120,000 numbers. Pretty neat, huh?
I think we are done, but what I like to see is your smiles. Isn't it beautiful? This is a story of hope. This is a story of journey to universal health coverage. So, Hans talked about development. I want to show that it's not everything, because we need to accompany that with a mindset shift. The idea that poor country can make it, and also be ready and open to innovation and work differently. Don't try, those best practices that we have to copy. It doesn't exist. You need to find your way at national level. However, based on data, and that's why I like Hans, based on data, and take decision accordingly. So Rwanda, you knew that I came, so I guess you did your homework. What is important to know is our GDP is $800 per capita. I hope you see that even my brothers and sisters from Africa, we are far below yours. That means development is not all, because we came from this genocide, 1994, country was destroyed. We were even not surviving, and nobody on earth were betting that we will make it. We decided to do differently. And I like the previous presentation who said political will is everything. We went behind the border and bring back home our brothers and sisters. Among them, there were a lot of killers. I have to tell you, I was there, I was totally shivering. However, it was a great decision, because keeping people in poverty outside their country, make them dream of something they will never have, and just is the nest of terrorism. So this is what Rwanda is today. We have claimed this, and we are above our brothers and sisters, even having a GDP that is less. We have double our life expectancy, reduced maternal and child mortality by more than 75%. And today, 91% of our women are delivering with a skills burst attended person. Very proud, to say that. But what is more important, we have the best kids vaccinated on earth. 93% of our boys are fully vaccinated for 11 vaccines. Girls is for 12 vaccines. 93. We still have $800 per capita. We don't have electricity across all the country. Supply chain, we have managed to do it because we are assessed and it's quality vaccination. So you can see here also where we come from for maternal mortality and where we are now. This is not so clear, but we have outpaced our sisters' countries. How we did so? Okay? How we did so? This I'm going to pass by, but there's a lot of steps to do so. We need to focus our development on human development. And to do that, you need to take care about the social determinant of health. Of course, people will tell you there is no money, there is no this, there is no that. Don't start before having that. Say the contrary, start. The money will come. Imagination will help you to fill the gap. But always think about the social determinant of health in general. It gives you the context. Also, create the system to have accurate data. How do you want to know that you are doing good if you cannot measure what you do? So investing in technology is key, meaning investing in internet across the country. In my country, you can go north, south, east, except in the foot of the volcano because they're too big, you have internet everywhere. And also it's provided by satellite, so it's different. But you need to know where your people are sick, where your people are dying, and where they are sick, and where they are dying, so that you can bring the care where it's needed. You have national information system, and after that you have data that you can borrow from IHME or other people who are aggregating data, but this is not enough. You need your own data, because sometimes when they aggregate, they give you the data of your brother countries. And you find that you have the life expectancy of our brothers from Kenya, and it's not the same. So you need both. You also need to educate your people to use that and standardize how to use it. So data collection, but also how you clean your data, how you generate your data, how you use your data. Data are not for the Ministry of Health, data are for those who are collecting it. So you need to create a system that reverse the channel. They come from bottom, but you need to give them also the access to the data, to the whole country data, but also to their own so that they can see what they are doing compared. It's good competition sometimes, because you can see who is doing good, and they can just take a bus and go and see what are you doing. And if you publish them, they always want to be the best. So this is the system we have created. We have 45,000 community health workers. We just add 13,000, so now it's 58,000 community health workers. It's 4 per each village, elected by the people, educated by the Ministry of Health, on a standardized way to take care of the patient so that we know what is going wrong. We doesn't have to guess. So we have many partners, but they have to apply one protocol. If they propose something else, we all sit around the table and we amend the national protocol. And the new one became the national protocol. And we educate all the service providers. This is the first line. They do that with a simple phone, not a smartphone. Those phones at $5, you know, almost nobody use those phones anymore, except the community health workers. They collect data, they report with it monthly. Those data are brought directly to the district, aggregate, but also to the Ministry of Health. To the district, because health belongs to the mayor. If you escape that, we talk about accountability. The mayor is accountable of the health of their people. And if you don't manage to create that, the ministry will always be useless. We are a number of people at central level, we can do nothing. However, the mayor, they are 30 with their team, they are near the people, they understand sometimes better what they need than in the ministry, and it's a dialogue. So, officially, it's the mayor who sends the data to the ministry. If the district is going wrong, it's the mayor that we call. What happened to your people? If there is embezzlement or if there is corruption, we call the mayor. You understand? So this creates an ownership at local level, but also the desire to do good. So in the end, data aggregate in the ministry, we know what happened, and we can see what we don't know, don't manage, don't master, and we can revise together the system and make it work better. We promote research, and this is something to show that Africa, we did good. Only 2% of the studies, the research are done in Africa. But even though publication, we are not there. So we need to promote and to change that. Doing research to better understand what is our sector, and doing research to understand how to act on it, but also doing publication. We need also to change the value of publication. I don't like what is there now. You are celibate, you do bullshit, they take it. Isn't it? They publish a name. Remember what happened with Ebola. Many high-level journals have got publication on Guinea, Sierra Leone, Liberia are endemic countries. However, people cannot pay that in those countries, and people here don't care of publication. They did that for academic growth. We should evaluate publication according to the number of lives they change, the wealth, the wellness they brought, not the number of people who read it, because there is a bias. To read it, you need to have access. What you do when you read it. So this may be something this institution can take over, like we try all in Africa to do. So to build a health sector, you need 4 S in 5. We need 5. The first one is the staff, human resource. Rwanda, the little we had has been killed, so we didn't have teachers. We cannot educate. So we borrow the teachers in the US with a mega project called Human Resource for Health. That's now several other countries try to emulate. Very good one. There is plenty of teachers that can give 1, 2, 3 months, 1 year to help African countries to have better health education. We had that project, 100 teachers from US were coming for a year during 7 years. Now our national university is better. We have also the staff, meaning we have money from HIV, TB, malaria. I have to say that there is very few money out of that, but we need to bring it together to build the health sector. What we did, we buy equipment for HIV and we make it used for everything, okay? We convince our partner that we need that microscope because malaria kills people with HIV, so that everybody can have their things assessed, etc. Biochemistry, same. You cannot follow somebody with HIV without have their biochemistry analyzed. So we have built almost 100 maternities, 100 emergency rooms. Almost all the labs of the country have been equipped with HIV money. The only thing was, don't say it. We build the health sector. We have also to assure geographic accessibility. So that means you create a system where all regions have the same access to the same thing. We share what we have. Create also financial accessibility. meaning we have created health insurance, and that's probably what the minister of Sri Lanka, was it Sri Lanka, was coming to see in Rwanda. Yeah, because we start late after many countries, but we have managed to make it work. And we have managed to make it work not because we are more clever, because we had a tool that I'm going to share with you. Information, exchange information and make the patient, give them agency is very difficult, especially when you have a big percentage of our population that was illiterated. And also that look at the nurse and the doctors like gods. So this is a very important thing. And the staff, I have talked about that, but in the center, quality care. Whatever you give, measure it for quality. And also make the patient giving, even illiterate, educated or not, the agency to hire and fire. Community health workers are elected. When people doesn't like what they do, they elect somebody else. We have to. Each health center, you will see here, at that level, bottom, you have the community health workers. After, you have a health post. There is a community committee that assesses how the nurse is kind. That doesn't mean that she's efficient scientifically, but at least she's at service. We assess at central level if the care is given according to books. The people assess availability, kindness, and encouragement. Because if not, people doesn't come. You can have the best care. You are not welcoming, they don't come. At the sector level here, we have a health center with a nurse with a degree. Only nurses. They care about delivery, and they provide antibiotics, cephalosporin, all those things very well. Task shifting. We don't have enough doctors, delegate to nurses. Stop the arrogance of belief that because you have 7 years or 6 years or 5 years in a university where majority of what you have learned is useless, that you do better than the nurse that know if you educate them properly. So after that, you have the district hospital, the first place where people see a doctor, and above the provincial hospital and the referral hospital and teaching hospital, where you have specialists and subspecialty. This is a pyramid of sharing scarcity. I agree with you. However, it works. Community health workers do work of nurses. They inject family planning tool because we have experience that people doesn't have the possibility to go the right day to get the injection and they get pregnant. So we did, so doctors were screaming, nurses saying, no, it works. People with diabetes, they inject themselves the insulin, isn't it? And they're less educated than a community health worker. So it works, and we have decreased, at least nobody can say, I had a baby because I didn't get the opportunity. And that was our goal. So this is the pyramid of care. Oh la la, no. And this is what it looks like. You have almost an equitable geographic access. One region, one regional hospital, one province hospital, one district hospital. Where you see nobody is because it's the national park and the national forest. And now, the third S is system and support, the fifth one. We need to create a system that doesn't belong to one person, so that when you are removed, the system continue, and that's how a country can thrive. And the system you create have to be inclusive, oriented for those who will not get access if you are not proactively going and search them. And this is what the majority of countries did. It's not a matter to create a fantastic system, it's a matter to create an inclusive system, where your focus as a leader is the poorest that will not come to seek the service, because they even don't know that they have that right, They don't know that the service exists, and they even don't know that they are sick. That's your job to solve those three issues. Also, gender equity, meaning in our parliament now, almost all the ministries in charge of human development had to say how they gender budget, what they do in their budget to reduce the gap of gender inequity. So efficient that now we are borderline 67% of women in parliament, and the constitution says that if one gender is not represented at less than 30%, elections are invalid. So now we are going to say, vote men, vote for men, vote for men. And all along, we ask people to, we put the problem on the table and ask people, how can we solve it with you? And give them agency, have given us tons of ideas that are adapted to our own system. Knowing also that being inclusive, UNICEF has shown in the study last year that $1 invest among the poorest in a country give $4 more in return. So there is, all those people who are going to be dishonest and deny all those studies that the predecessor on this desk have shown, they just don't want to see. They don't want to understand because there is enough studies who allow us to know what to do. This is also a slide to show that with inclusiveness and the way to proceed, you reduce maternal and child mortality. We have that for everything, even for access to HIV treatment. You get more with less dollar, even not $100 per capita, but we have reduced the mortality far quicker and deeply than with other approach. So this one is to say that corruption, we always talk about the poor doctor who have still some money in the district. What about international corruption? I'm not going to insist on that, but there is billions of dollars that evade tax from Africa to come in those countries. And if this was remaining in Africa, no need of help. So the real fight is fight this international corruption and use of the money on the benefit of those who want the money, but on the benefit of the continent. Next, this is the same. So, bottom line, health is a human right that we need to protect as government. So, because this is the definition, a government is obliged to respect human rights, to enforce it, and to punish those who contravene it. We need to give priority on universal health coverage. However, I don't say that we are capable today to give sophisticated care, but we have to share what we are allowed, what we have, and treat the people where they are, geographic access, and explain and give agency to the people. To do that, we have also created a system of comprehensive governance. Every month, the ministries at the level of director, at the level of permanent secretary and minister meet at those levels to discuss the novel policies they are going to propose. To be sure that health is concerned in labor law, that gender is concerned in health, that youth are taken in account, so that we work in synergy is less costly. And you can see that there are 3 clusters that are meeting. It's not a cabinet, it's nothing. We just share what we have to do. And if we didn't share it, it doesn't go to the Prime Minister, and certainly not to cabinet. So we have gender, sport, culture, local government, health, education, and it's shared by the Minister of Education or the Minister of Health, the 2 major human development sector. Also, it is cross-cutting, doing that cross-cutting in each and every document. And that's how we fly. But we still have opposition and those people who just say, this is Morris King, published in The Lancet, saying we should not give oral solution for rehydration to children, to Rwandan children, because they were promised to a miserable life, published in The Lancet, a UK journal. Huh? We have also those who are saying HIV treatment is not for us. However, adherence in Africa is better than here. However, this is a study done from a Canadian university who showed that we have 2 times better result than New York for HIV viral load suppression. So all is not about economic growth, it's about mindset. And also, we have now HPV vaccine, 93% of girls vaccinated. These are the people who deny science and deny evidence. Okay, I love this. And of course, they wrote in The Lancet that I sold my girls to a farmer, and I answer, because thanks God, I know how to write. However, this is really not acceptable. We should keep some ethics in some publication. So I see that it's time to move to the Q&A. But what I want to say, we need a vision, we need data, and we need flexibility and we need also to stop designing things like that. You give that to a minister, it's okay. I have a deck now, I will see tomorrow, and tomorrow never happen. Make things simple. And for that, we have created a University of Global Health Equity. Equity is in the title. It's for nobody to forget that we have to leave no one behind. And this is it. That was, the campus was open 2 weeks ago, but the university is running since 3 years. It's a beautiful campus, no more costly than to do an ugly one. And what is important is what we teach in. Thank you.